Hello, my name is April Burns. I will be presenting the cultural group for individuals who suffer from psychogenic non-epileptic seizures. This is the population presentation for multicultural class here at Texas Tech University, taught by Dr. Kim. What is PNES? PNES stands for Psychogenic Non-Epileptic Seizures. This group suffers from seizures consisting of involuntary and sudden changes in behavior, sensation, movement, and sometimes consciousness as the brain detects physical or emotional distress, or even both, in reflex-like responses, usually demonstrated through physical symptoms, as the brain uses these to express distress and discomfort involuntarily and responds to a stimulus that does not enter the person's conscious awareness. It is often mistaken for epileptic seizures by health professionals because of the similar presentation symptoms. There are many various symptoms and signs of PNES. Symptoms are those that individuals feel, whereas signs are what you or others observe. According to the information on the PNES website from Dr. Lorna Myers, they may experience an aura, which is considered a warning sign that happens a few seconds or minutes before the person has a seizure. Not all PNES sufferers have them. These may include symptoms of lightheadedness, hot flashes, strange tastes, smells, or sounds, visual disturbances, headaches, and even nausea. Individuals with PNES may have motor or movement issues like intense shaking movement of arms, head, or legs. The presence of pelvic forward thrashing suggests PNES over epilepsy. When it comes to awareness and consciousness, the cognitive functioning can be impaired. Some can remember the episode while others do not. Other signs may include becoming mute, crying and screaming, may experience biting their tongue, losing bladder control, or even falling to the floor. This cultural group has no boundaries. It affects individuals from various backgrounds, which makes it difficult to define this cultural group. With such a lack of empirical research and information, it can be difficult to actually say how many individuals suffer from this condition. These seizures usually occur in people who suffer from conversion disorder, dissociative disorder, functional neurological disorder, and PTSD. We know they make up their own cultural group, since most share many characteristics regarding symptoms and signs and many other aspects of their condition. There are many relevant statistics related to the PNES culture group. There is an estimated an average of 3 per 100,000 each year diagnosed over the age of 18. Most of these seizures start in a person's teenage years, but also can have an onset between the ages of 25 and 35 years old and occur more in women than in men. It is estimated that 49% of patients with PNES have additional psychiatric comorbidity. The mortality rate is 2.5 times higher than the general population, and the 20% of individuals with PNES suffer deaths from suicide. The approximate statistics of comorbidity in PNES patients include depression, which is 38 to 54%, anxiety, which is 25%, chronic pain is at 57%, and trauma-related is broken down between non-sexual at 86.6% and sexual at 30%. We will now look at the social political aspects of PNES individuals as it relates to the history. In past history, the condition of PNES was called hysteria and thought to result from a wandering uterus that was attached to the other organs causing physical symptoms. But the theory was discredited by increased reports of males having it. In the 19th century, John Charcot identified the condition as a neurological disorder with psychological underpinnings thought to be treated with hypnosis. Later, Sigmund Freud believed it was a form of the body converting repressed impulses into physical form, in which he called conversion disorder. As time went by, Pierre Janet suggested hysteria was dissociative during stressful times as the individual experienced the past traumatic event while separating the memory from the conscious awareness. Sadly, in the present day, much more needed neurological research must be done to link the pathology of PNES, and it is still a condition that is vastly misunderstood. As we continue with social political aspects, let's turn our attention to social justice issues. Social justice issues for PNES cultural group are not addressed as they should be. PNES can be mistaken for epilepsy until the proper testing is done on the individual, which can harm the client if treated with intubation and medically induced comas, like commonly done to individuals with epilepsy. Sometimes medical professionals prescribe an anti-epileptic drug before a video EEG is done, causing unnecessary medication therapy and possibly resulting in negative side effects. The mental anguish can be daunting for PNES individuals and can take an average of 7.2 years before a PNES diagnosis is given. From the little information provided, it is obvious society has caused these individuals to receive inadequate care. They've only conducted a small number of research studies. They have provided unnecessary medical procedures and having them suffer for way too long. It is obvious something must be done. In the culture, identity, and structure of individuals with PNES, I want to point out that this cultural group is rarely recognized by society, so it is difficult to explain the actual structure. There is little on how it shapes these individuals' identities. Having medically unexplained symptoms results in challenging the social identity of the patient. This challenges cause individuals with PNES to experience a lack of support from the community and even their own families. Many PNES patients identify as being traumatized by the effects of the condition itself and social, occupational, and other environmental settings from the stigma. This can contribute to low employment, social support, and income. And there is a higher alcohol consumption rates, poor diet, and smoking for individuals with PNES. I want to take the time to share my own personal experience of talking to individuals that suffer from PNES. Please listen carefully as these individuals express what they face. I first spoke to Seth, which is a paramedic and firefighter that suffers from PNES, and he states, I experienced psychogenic seizures after having epilepsy. Because of my epilepsy, I had to have brain surgery where they took out my right prolobe, right hippocampus, and right amygdala, eliminating my epileptic seizures. 2 years later, I started having PNES after witnessing a traumatic event involving my wife in a car accident. One time I hit my head after having one, and my wife made me have a CT scan, which I felt silly when doing it because I felt fine. While there, the nurses found out I had PNES wrote me off, and even made a few jokes they thought I wouldn't understand because they did not realize I was in the medical field. Now I'm doing CBT and working out my emotions since my surgery took out most of my emotional power plant. My coworkers do not understand this condition at all. I have learned to have a heart for these people, especially since I suffer from them as well, and I am a EMT that actually treats these type of people. Another individual I spoke to was Rebecca, a mother of a 16-year-old who has PNES, where she said, "My daughter is 16 and has PNES for about 2 years now. She is in a one-on-one learning environment at school due to PNES, which is a less stressful environment. She has a history of OCD, anxiety, and ADHD. She has a difficult time talking and understanding this, and because of this, she doesn't open up to the therapist like they want her to. Having PNES has affected her tremendously in so many areas of her life. We recently went to the ER the other night because of her seizures would not stop. I had to educate EMS on her condition and some of the emergency staff. This is so frustrating because no one seems to know anything about it or can effectively help her. It breaks my heart as a mother to see her go through this." As you can see, these individuals with PNES come from different backgrounds, different ages, and medical professionals have different views on why they are experiencing this. One of the most important socio-political aspects of the PNES cultural group is the stigma tied to it. Stigma seems to be reported as higher than in epilepsy patients. Negative views of PNES are linked to the disparaging use of psychosomatic in the media and is viewed as a fake illness. Most PNES patients feel abandoned by medical professionals, and many patients are viewed as faking it. Many PNES patients do not feel they are being taken seriously or listened to. The legitimacy of the illness continues to be questioned by professionals. There is a lack of investigations, but past research that we do have shows many PNES patients deal with discrimination from health professionals because of their poor understanding of PNES. Assumptions of malingering are the most apparent stigma. Some professionals have suggested PNES individuals have a factitious disorder. A PNES patient having a factitious disorder is possible but unlikely if there is no secondary gain. Even the sick role in a factitious disorder may be unconscious, but the act of deception is purposely done and conscious. The stigma they face is one of the biggest barriers in these individuals' lives. Since stigma is a common occurrence for people with PNES, I would like you to watch this music video created by an artist that suffers from psychogenic non-epileptic seizures. This artist is a major advocate for PNES. Please be aware this video may contain graphic images and language.
I've never seen my own brain, such a shame, what the hell are we? Exoskeletons in the rough, Our brains are aliens in animated mush. Make me cry, call me alive while I'm spitting fire. Can't imagine how it is, it's insane. They ask me, how do you love? By the way, there is pain you can't see. So when did you decide that I was faking? By the way, there's pain you can't see. So when did you decide that I was faking? Crash, boom, fly, London bridges crashing down. Hit, smack, scream, crack. Shouldn't you be catching me? My brothers and my sister don't know who I am. Everyone around me thinks it's all part of my scam. Like you think I'd have the time to suggest I'm unimpressed. I just refuse to let my flame get dim. So sink in, just catch me if you can. By the way, there is pain you can't see. So when did you decide that I was faking? By the way, there is pain you can't see. So when did you decide that I was faking? Crash, boom, fly, London bridges crashing down. Hit, smack, scream, crack. Shouldn't you be catching me? Yes, leaves me out of breath. Let my chest stick in heavy and see. Will I wake up or am I dreaming? Ask me today. Hope I remember my name. Hope you remember my name. Hope you remember me. Wake up. By the way, there's pain you can't see. So when did you decide that I was faking? By the way, there's pain you can't see. So when did you decide that I was faking? Crash, boom, flat, London bridges crashing down. Hit, smack, scream, crack. Shouldn't you be catching me?
Say it again. Now what? She just had a seizure because of the police cars flashing lights.
If you stuff like this, things can be hard.
I felt a little down. Spicy, where I think really getting
Oh no, honey.
right.
We got her
I'm
just.
doing it for fun, so I'm thinking I'm talking with around a little bit.
We won't say what your first word was.
I didn't know what it was.
You'll say it again if I ask you. Yeah, right. See, you know. Oh God. All right, just lay there till you feel better. We got our sunglasses.
I've never seen my own brain, such a shame. What the hell are we? Exoskeletons in the rough. Our brains are aliens in animated mush. Make me cry, call me alive while I'm spitting fire. Can't imagine how it is, it's insane. They ask me, how do you love? By the way, there is pain you can't see. So when did you decide
Other than the symptoms and signs in PNES individuals stated earlier in this presentation, there are also mental factors as to why medical professionals think PNES develops, which includes trauma, family dysfunction, psychopathology, coping styles, personality factors, and possible neurological abnormalities. Although we lack empirical evidence to suggest physical aspects of this condition, there have been possible medical explanations as to why these seizures occur. One possible medical explanation that could be derived can include the amygdala and the frontal lobes of the brain. There are two amygdalas on each side of the brain that is part of the limbic system, which holds emotional memories. It automatically activates the fight or flight response and is triggered by emotions like anxiety, anger, and fear. The frontal lobes are in front of the brain, are responsible for reasoning, decision making, and thinking logically to make a decision, and you have control of the response, unlike the amygdala's responses. If a threat is mild, the frontal lobe may override the amygdala, but if the threat is serious, the amygdala overrules the frontal lobes. Unlike early human years where we were faced with more physical danger, we are now faced with more psychological stressors or threats that can cause emotions, and the amygdala senses a serious threat, which then activates the fight or flight response, and it shouldn't have. Although not specifically suggested in the amygdala hijack article, I believe this could be the beginning of the need for research. It is suggested that we would benefit from more research on emotional regulations and pathology, and until these types of research studies are done, PNES individuals are left with a condition that has little explanation. At this time, medical professionals are not too confident about the treatment of PNES, but normally direct PNES individuals to the mental health aspects of treatment and rehabilitation. With this condition being so unknown, PNES individuals often feel shocked and confused about their diagnosis. Most patients do not see it as psychological because they experience physical symptoms, so they question their sanity. They feel trapped and powerless by the condition and are not given the support to deal with such an uncertain diagnosis. Individuals with PNES often have a physical disability when some of them experience temporary paralysis, requiring them to also participate in physical rehabilitation. It is possible because of the lack of research studies and knowledge of PNES by medical professionals. It doesn't surprise me that there is little consensus on the lack of terminology and classification in the DSM-5, and currently PNES is a classification in conversion disorder, which is found under the somatic symptom disorder category. There are often delays in psychiatric help for individuals with PNES, which can relate to assisting with poor working memory and executive function and contributing to these issues as well. This can cause such mental disability for these individuals because their cognitive functioning is impaired, leaving them unable to participate successfully in an occupation. This impairment is not recognized by the Social Security Administration, which leaves them with no way of having financial support. The counselor's role is vital in helping these individuals, since at this time it is thought that the seizures are derived from mental health issues. Counselors must have previous experience and training to perform a formal psychiatric assessment, and they must do this before moving on to an established treatment plan. Counselors must communicate with other healthcare providers caring for the PNS patient to ensure what the individuals face on the medical side of it, and share the knowledge of PNES with healthcare providers that are uneducated about the condition. Counselors need to advocate for change for individuals with PNES on levels such as political, social, academic, and healthcare platforms. Counselors need to provide an adequate treatment plan to treat any other mental health comorbidities to help alleviate their disability of PNES. We will continue on how counseling can help create solutions for major barriers individuals that have PNES face. Counselors should make a concerted effort to tackle these barriers head on. Some of the measures counselors can take in coming up with solutions can eliminate major barriers such as the agreement on terminology, the types of discussions needed, the billing and coding procedures, the classification of outcome measures, lack of interest and lack of research studies, and the hesitancy to be treated by psychiatrists and neurologists. It is obvious that individuals express their experiences on social networks and other platforms in which PNES has become a worldwide condition that must be seriously addressed. As you can see here, there are not too many support groups and support materials to assist with PNES and their cultural group. Please feel free to look over these resources and even join to learn more about this condition. Effective communication is the first step to managing PNES. Many patients are unaware that psychological therapy is a treatment option, and it can be difficult for counselors, especially when PNES is not a separate disorder in the DSM-5. Psychotherapy is the treatment clinicians use to treat PNES. Psychotherapy approaches may include cognitive behavioral therapy, which is also known as CBT, and it is used to interrupt cognitive responses at the beginning of the seizure, like engaging in avoidance activities, bringing up low self-esteem, mood, and anxiety, and looking at negative thoughts and beliefs on PNES occurrences. CBT can be used and recommended to see results after 12 sessions. Another approach is EMDR, which is eye movement desensitization and reprocessing, which is used to alleviate the distress caused by traumatic events. Next is psychodynamic interpersonal therapy may help address unhelpful ways of relating to others and managing emotions and creating safety for them, especially since they have to deal with the stigma. Then you have biofeedback, which involves giving auditory and visual feedback to patients to allow them to get control of involuntary functions of the body physically and mentally. Then there is operant conditioning, which may help the individual's behavior by helping them to be aware of the consequences of their negative behavior. You also have hypnotherapy, which is where the subconscious mind is reprogrammed. And lastly, you have family and multidisciplinary therapies that can help individuals deal with social concerns. Since an accurate diagnosis can take several years, delay in psychological treatment and an accepted theoretical model lacks for PNES. There is a major lack of ownership of PNES from mental and medical health professionals, which can be the major cause of little advances and therapeutic studies. The fact it can be shuffled between neurology and psychiatry for years indicates that professionals in either field do not want to look further into finding specific reasons for the condition. There is a need for communication between neurologists, psychiatrists, primary care providers, and therapists to diagnose PNES in a compassionate way to minimize stigma and create a strong therapeutic alliance. Even EMTs, ER doctors, and nurses have limited knowledge. As we come to a close of this presentation, I would like to say that PNES is a condition that we have the duty to our clients to be fully aware of and knowledgeable of. As counselors, we must take the time to understand this condition for the thousands of individuals who have to deal with this misunderstood condition, and I hope this presentation gave you a clear understanding.